Thank you for watching this video. Please subscribe to my YouTube channel and follow my Facebook page. Please also support my work on Patreon and Kickstarter. It will be greatly appreciated. Can you see this well? Okay, let's start from all the way up here at the level of T12. What is A and what is B? A is the liver, absolutely. Descending or abdominal aorta is also all right. Okay, good job. Next one. Now we're at T11. All right, yeah, we can say that. You know, if you wrote that as the abdominal aorta, I wouldn't consider it wrong because it's right. Yeah, it's right at the brink, so, you know, these things. Oops. Yeah, I think, again, same thing, aorta, and maybe now it's the abdominal aorta. I can't say. But let's just call it if you call it descending aorta, we couldn't go wrong, could we? All right, so now, okay, so T9 lower. Now we've got a few structures. So have a look and let me know what you think they are.
So A would be the right ventricle.
Correct.
B would be the inter-ventricular septum.
Correct.
C would be the left ventricle.
Correct.
D would possibly be the atrium.
That is true. I think you can't see it. It's a vessel.
Oh, okay. So vessel could be the left part.
And no, it's too low.
So we're nowhere near. Sorry, yeah, we're nowhere near that. What am I looking for? Is it right coronary?
It can be the right. Yep, it is the PDA. Absolutely. Good.
E would be descending aorta.
Correct. I am sorry we didn't do F, but yeah, give me a guess.
Is it just the left crus?
Is it what?
The left crus is the diaphragm.
No, it's not it's not that diaphragm. It's an artery. It's a vessel.
Oh, is the posterior.
You got one. Yeah. Yes. Costal. You got it. Very good. Yeah, I had to explain that. I missed it. Throughout this area, the aorta gives two posterior intercostal arteries at every level. Absolutely. And I'll definitely do this when we do the thoracic wall, but I could have shown this to you a bit here, forgotten it. But yes, that's where the posterior intercostal artery is. All right. Good job. All right. What is next? Let's do the next slide. Yep, that's the next slide. We're slightly higher up.
I think A is probably the IVC.
A is the IVC. Correct. That is the liver. The diaphragm and liver, it's very hard to differentiate between the two because the diaphragm is so thin. You know, it almost, as soon as the liver ends, the diaphragm also ends with it. But well, let me, now that I say that, I can tell you what, I should have that Horace. Here, here it is. I shouldn't have shut it down. There it is. I'm getting slow in my computer skills. I think it was this one. Yes, it was this one. So I do want to say that yes, the diaphragm and liver are very close by, but except when you look at it in this view. In this view, it's a bit hard to see. You see how thin the diaphragm is. And so even here, it's a bit hard to see. Maybe if we magnify it, we'll be able to see a bit of a difference. You shouldn't magnify it too much. But nah, it's again very hard to see any difference between the diaphragm and the liver. However, if there's a mass here or fluid here, there are three things here together. There's the liver, there's the diaphragm, and there's the pleura. And then there's the lung. And all three of them just look like one space. And then when we will do the, unless they're gas or air or water. So when we will do this area again in the thoracic, when we do the lungs, we will see if pleuritis can get, pleural fluid can get here, air can get here, and sometimes you can get air under the diaphragm. That's what we'll do when we do the abdomen. So these are the layers here. It's the lung, it's the both pleuras, and the diaphragm, and then the liver, which you cannot. All those structures are here, but it's like one straight line, so it's hard to tell. But I guess you get the point. And so yes, you cannot tell too much of the difference between the liver and diaphragm at this point, and pleura. Correct.
That would then be the right ventricle.
Yep, right ventricle. Correct. You can keep answering, even left ventricle.
Yeah, I'll try not to go too simple.
Yeah, I'll keep going.
Okay, so again, we're looking from the bottom up. I would probably say 0.9. Is that still
Yes.
the
Yeah, it is PDA, but you can.
quite
Yeah, it's quite chunky there. PDA, or you can call it the right coronary now, because it's right there in the atrioventricular septum. So the PDA would be going this way, but yeah, you could call it the right coronary. But PDA is also not wrong. If you wrote PDA right there, then it's correct. And after this, yeah, aorta, exactly. All right, good. We're getting there. All right. So similar structures. We can start. No, actually, a few extra structures have been added here.
Yep. So A, I would call the right atrium.
Correct.
B, I think is the start of the left atrium.
I think so. I don't know if I was thinking coronary sinus there, but
Oh, right.
but coronary sinus would be there too, wouldn't it?
Coronary sinus would run just slightly above it on the CT.
Fair enough.
Above the left atrium.
Yeah, let's just put it as left atrium. All right, that's fine.
Yep.
I don't know what I was thinking.
The right ventricle.
C is the right ventricle, I guess. Same thing. Yeah.
Left ventricle.
And the descending aorta. All right, good. We're getting there. Good job. Good job. What's that little hole? Is this an extra thing? We didn't do it, but let, I, the azygos. No, the azygos is right here. A structure that would have air in it at this point.
Oh, it's the it'll be the very end of the trachea.
No, the trachea is bifurcated. Part of the GIT. Part of the GIT.
Oh, the thoracic duct.
No, not the thoracic duct.
Oh.
That's
Oh, that has. Sorry, that's so dumb. That has
esophagus. That's the esophagus.
tiny. Oh, it's tiny.
Well, it looks tiny. Sometimes it's got more air in it. But as you go, when we do the GIT, I'll do this again. I just thought I'd pull that out here, just to. But when we do the GIT, I will show you that. I'll show you the thoracic passage of the aorta, of the esophagus. But that's exactly where it is. It's right next to the aorta. It's behind the trachea, and then when the trachea ends, it just becomes next to the aorta. No, that's right. Nothing like that. Okay, so we've got more structures now.
Okay, so A would be an atrioventricular. Oh, it might be. It's not the coronary sign.
That's not the coronary sign. AV groove is fine. Or and the right coronary artery would be here also, but you can't see it.
Right,
Coming down, yes, absolutely.
Yep, right atrium.
Yep, B is right atrium.
And then left atrium.
Left atrium. Correct.
Call the
Right pulmonary. Right inferior pulmonary vein. Correct.
Yep. E would be the right ventricle.
E is the right ventricle. Yep.
Left
Yep. I ventricle. Left ventricle.
and descending.
Yep. Aorta. Descending aorta again. Okay, good. Let's keep going.
Yep. So A. Again.
Oops.
Still the right atrium.
Yeah, still the right atrium. Correct. Not the IVC.
No, because that would be below the right atrium. Is it the SVC?
It's the SVC. Correct. I think it's superior now. Right pulmon vein in superior. Let me. Do you want me to check? Because I complete. Okay. Yes, I think I would base it off the SVC. It would be this. Yeah, absolutely. No, no, that's too low. Pulmonary vein left will go into what chamber? Yes, that's the left atrium. That's the left atrium. That's the left atrium. Yep. I think that's what I would be doing. The left atrium, absolutely. E would be the right ventricle, correct. Yes. Inter-ventricular septum. It is. It is the ascending aorta. Some might even call it the root of the aorta, because that's where the aorta just starts. Yep. Left superior pulmonary vein. Yep. Yeah. Descending aorta. Correct. Correct. All right. T6 level. So I think that it's the same level, but I just like focused a blood vessel.
So A would have to be your myocardial artery becoming your left atrium.
Correct. That's left anterior descending. And B would be?
And B would be LCA.
Left coronary artery. Yes, almost immediately. Absolutely. All right. And that's another coronary artery.
Yeah, that would be your circumflex.
Circumflex. No, the circumflex only is on the left side.
Yeah.
So you actually can call it circumflex artery and not to tell the side. All right, that's done. And yep, we're slightly higher up. This is an important, probably one of the very important levels.
Yeah. Okay, so A would be the ascending.
Correct.
B would be the SVC.
B would be the SVC. Yes, correct.
C would be the right pulmonary artery.
Right pulmonary artery, correct.
D would be the pulmonary artery.
Yep, correct.
E would be the left pulmonary artery.
Correct.
And F would be the descending.
Correct. That is correct. Good job. And all right, what is next? All right, here we are. T4 level.
Okay, so A would be. So I'm looking at B is the arch, so A would be the SVC.
A is the SVC, correct. And B is just B, you just said so, the arch of the aorta. Correct. All right, let's keep going. Yep.
So I think we still have A as the SVC.
Yep. No, A is not the SVC now. A is not the S.
It would have to be then the right brachiocephalic.
Correct. Right brachiocephalic. I don't know how to spell it.
So you can tell because B is the left.
Absolutely.
You can kind of see that one.
You are correct. So B is the left.
Yep.
And C.
So a little past the arch, which means C would be the brachiocephalic trunk.
Correct. Brachiocephalic trunk. And D.
And then C would be the left common carotid.
Correct. The left common carotid artery.
Left.
And this is left subclavian artery. Correct. Well done. For one go. Photographic memory. Well done. All right, what's next? No, I'm thinking. Oh, yeah. Oh, yeah.
Sorry. Okay. So, okay. So coming up into the neck, that would have to be A. Would have to be the right common carotid.
I believe it is. Yep. Right common carotid.
And B is probably tracking across. I'd say right.
Right subclavian. Yep.
C. Just trying to think.
And yes, right subclavian artery.
Well, artery.
Yes. Common carotid is an artery, but yes.
Yeah, subclavian artery. So, just trying to think. So if you ready? D is the left common carotid.
Correct.
The left subclavian.
Yes. And this is the left subclavian artery.
Oh, is it it's not the left brachiocephalic vein, is it?
No, but it could be. That's a good question, because the left brachiocephalic vein forms from these two veins.
Oh, okay. So yeah, right. If it's sitting next to the common carotid, it's probably the left internal jugular.
It could be the internal jugular, or the left subclavian vein. I don't know what I'm doing here. So let's figure this one out. You know, sometimes I often confuse myself, really. And okay, so we are where are we? We are up at this level, and I have labeled this and this. Now we're slightly higher up. So I've labeled this, and this, and this. That's what it is, isn't it? Let me just see. It's a slightly different contrast, but yes, that's what it is. So we've got this label, this label, this label, and that's what it is. And that, yes, and if you look at it, that I should have put an arrow here, because that will become the internal jugular, which you are right. That will become the internal jugular. So that's the internal jugular vein. And this here is the subclavian vein. So you're very right. So when you said internal jugular, you're not wrong, because this is the area where the internal jugular and subclavian are meeting. So this could actually even be called the brachiocephalic vein. So you're actually not wrong calling it the internal jugular and the subclavian. It is actually, I should have pointed it to either out here, but because I'm pointing it right in the middle, it's confusing. So you know, if I pointed it there, then that would definitely be the subclavian vein. But I'm glad we had that discussion. The discussions are good because they teach you a lot. All right, so you got that right. Well done. All right, let's keep going. Okay.
Alright. So can I just ask, that's obviously the trachea, just running.
Yes, that is the trachea. Absolutely.
Okay, so I'm going to say A is the left common carotid.
That is.
Or is it
No,
more than the other side?
it's not. It's not left.
Oh, sorry, it's the right. Sorry.
Yes. Right.
Is that how you would distinguish jugular vein from common carotid? Just that the carotid is smaller
And medial.
and medial. Okay.
Yes.
Thank you.
And yes,
That
B
used to be
is and you're
right internal jugular
right internal jugular
vein.
vein.
And at that level, it seems to be a right vertebral.
Correct. What?
Okay.
Artery or vein?
The
Artery or vein?
sorry. Well, it's posterior, so the artery.
Correct. And can you tell the right vertebral vein?
Yeah, just that little,
Th-
the bigger surface.
Yeah, that's absolutely correct. Very good.
Okay, so D, internal jugular vein, I think.
Yes. Vein, correct. And E?
And E, yeah, would be the left common carotid.
Left common carotid, yep. Correct.
And then F would be the left vertebral
Left vertebral
artery.
artery, correct. And can you see the vein?
Yeah, just slightly ahead.
And that is it.
Yeah.
Excellent. All right, and that's it. I think, did we cover everything? I think we did. Absolutely did. Let me just check. Most of it we did. I think the only thing we didn't talk about was the azygos and hemiazygos. Let me see if I have an image of that. No, I think I missed the image, the level. But let's just do the azygos again. Let me make a note of that. Maybe I should put an add azygos. And internal thoracic. Oh no. I missed those in the quiz. So, can you tell the internal thoracic vessels in this level?
Yeah, I would go left and right of the vertebral.
Yep. That's the artery and that's the vein. Internal thoracic artery and the vein. The artery is more lateral here. And you'll see it at every level, you know. Oh, that's a bit high. But if you go lower down, it doesn't show too well here, but you can see it here. Here it's also right. Yeah. Little bumps, absolutely. And the azygos we didn't do, but I'll show it to you again so that you remember it. The azygos is when you see the aorta, you see this other structure that's joining it. And at that level, right there, that's the azygos vein.
Yeah, right. Yeah.
And
Behind.
around higher up, after the bifurcation of the pulmonary arteries, more superior to it, then you have the azygos vein. Let me just, that's exactly where it is actually. Let me show it to you again here. Azygos vein. Vein, not veins. Okay, so which diagram has a nice version of it? But it doesn't show the pulmonary arteries along with it. Actually, none of these show it really well. Maybe this one. Yeah, this is actually good. The diagram is in open image in your tab. Let's see if I can get a big version of it. It's fairly big. So look here. That's the azygos vein. That's the IVC. Yep. And you can see a few other things. That's the tracheal bifurcation. That's the trachea, the bronchi, primary bronchus, after the tracheal bifurcation. And this is on the right side. Those are your pulmonary arteries.
Yeah.
Sorry. Pulmonary arteries. Those are the pulmonary veins. So those are your pulmonary arteries. And the azygos vein is on top, is superior to the right pulmonary artery. Because these are your right pulmonary arteries.
Yeah.
So if you go here, and let's look at the right pulmonary artery. That's the pulmonary artery. So that's the right pulmonary artery. So we have to go superior to this. So and that's your IVC. So when we go superior to this, you should see the azygos come along.
Yeah.
And we can see it in this view, which is always good to see it in. Okay, where'd you go? Okay, now here is the azygos. That's the azygos vein. Can't see it too well here, but you can see it that it goes above the tracheal bifurcation. It's the same thing. So if you look at this diagram is sort of essentially, I mean, this is a coronal view. It's almost similar to what you're seeing here, except that this is a dissection and we're looking at it from the front. But this is exactly what you're showing here, that the azygos is coming across and under it is the right bronchus and pulmonary artery. And here, if you look here, you can see the bronchus right there. And that's the an azygos vein, and the pulmonary artery is just under it. Now, if I go to the right pulmonary, if I click on that here, then that down there is the pulmonary artery. So here you can clearly see, that azygos vein, right primary bronchus, and the pulmonary artery, and you can see the azygos covering over it. So that's really cool. Okay, so that's done with the azygos, and I think we're also done with the quiz. I thought the only thing we missed in the quiz was the azygos, and the rest is all in there. And there's a thing called the aortic pulmonary window. I have it written here. You'll hear of it in a couple of things because there are lymph nodes there, etc. And it's an area in the mediastinum which is actually relevant also. The aortic pulmonary window, the reason what they call it is, if you look at it here, you see the arch of the aorta, and as you go, I'm going inferior to the arch of the aorta, you see the pulmonary artery divide into right and left. So also the aortic pulmonary window is the space between the pulmonary artery and the arch of the aorta. So if I go superior, this is the aortic pulmonary window, because it is below the arch but above the pulmonary artery. So that area is the aortic. So that's the arch, and that's the pulmonary artery. So it's below the arch but above the pulmonary artery. And the reason it's a relevant, there are lymph nodes there, and it's just if you do thoracic lymph nodes, we'll talk about it, and we're going to do thoracic lymph nodes in two sessions. So I just thought I'd mention it here, and that's called the aortic pulmonary window. Yes, the oblique. Yeah. The oblique and transverse sinuses are actually areas in the pericardial sac. Oblique and transverse sinus in the pericardium. There you go. So how does this is a good image. If you got into the pericardium, you could actually put your finger behind these because there's a space behind them. It's a cardiothoracic surgeons know of this because it's one way to not cut the heart. Or if you cut the heart, if you cut the pericardium, here they show the pericardium is cut. And if you cut the pericardium, you go under these structures, you can sort of get your finger across, and under these structures you can get your fingers across. And that's the transverse sinus, and that's the oblique sinus. So it's yes, it's not of too.
Can you show on that diagram with the finger behind where the aortic
Aortic pulmonary window is right here. Yeah, but that's the right. Yeah, it's right near the ligamentum arteriosum. Ligamentum arteriosum is in the aortic pulmonary window. Yep.
Okay, cool.
Absolutely. So these oblique and transverse sinuses are relevant particularly for cardiothoracic surgery. You'll never hear of it otherwise. But if you were rotating in cardiothoracic surgery, you'll hear of it because sometimes when they need to get to the mitral valve, etc., they use these areas. The aortic pulmonary window you are going to hear a lot in radiology because that's where they're looking for lymph nodes. So people with lung cancers or mediastinal cancers, they'll be looking for lymph nodes in that area. So aortic pulmonary window you'll hear of if you're rotating in radiology, or if you're rotating in respiratory physician because of lung cancer. And you probably will also hear it in cardiothoracics actually, because they have to think about things there also. Yes. What else? There was something else I was thinking, and it has. Yep, I think that's it. All right. And no problem. Another thing. I've got to make a note of that. I made this mistake last time also. I don't talk of the pericardium and the pericardium. You can see here. You can see very well. Look, you can see that's all the heart, but you can see there's a layer around it, and that's the pericardium. And the pericardium sits on the diaphragm. So the diaphragm has a tendon in the middle, and that tendon is actually continuous. The fibrous tissue of the tendon is continuous with the pericardium. So you can see the pericardium here in the heart. You can also see the pericardium. You can see that layer around it. In some places you can't see it, but that's the pericardium. And here you can also see the pericardium, around these structures over here. And you can see it. You can see some pericardial windows here. So the pericardium is an important structure that you should be able to visualize, as long as you know it's around the border of the heart, because you get pericardial effusions and sometimes edema and fluid in that area. So you should just know where that is. Which you do know where it is, but on a CT, it's been demonstrated to you. Let's just say it that way. All right. Okay, so let's just go straight into the pathology quiz now. Now, where's the pathology quiz? All right, cardiac pathology quiz. And here we are. Do you see any? Do you see? What do you see? I mean, there's so many things, but look at the size of the heart, I would say. Cardiomegaly, absolutely.
Probably got a slight lessening of the thickness of the left ventricle.
That's true. The wall looks, or at least the chamber looks larger. Yeah.
Which could be more like a dilated.
Yes. Or just a dilated failing heart, absolutely. So you're right. You got it right. It is a dilated heart.
Okay.
Good. All right. Next one.
Okay, so the size looks okay, but the wall looks quite thick.
The wall looks very thick. Yes, on both sides. Yep.
So maybe lack of hypertrophy.
Good one. But let me take you somewhere. Hypertrophy, potentially, but let me take you somewhere else. What if this is? If you see that, what if that is the myocardium? What if this was the myocardium? This area. And this is the chamber.
Yeah, right. Pericardium.
Pericardial effusion, absolutely. So you got that correct. That's a pericardial effusion.
Okay.
So it's fluid in the pericardium.
Between the wall,
Yes,
what's happening in the pericardium.
yes. So you can see this line here, and that looks like the myocardial wall from the outside. And so that is a pericardial effusion. It's fluid in the pericardium. All right. Let's look at this one. Now, where is the problem here? And now let me just look at the answer first. Of course, how could I forget that? The problem is here.
Sure. Yeah. Like essentially like a valvular calcification.
Yes.
I was trying to figure out if it looks like, it's coming out of the left ventricle, so you'd assume.
Yes. And so, that's a calcified aortic valve, and that is left to a left ventricular hypertrophy also. You can't see the left ventricular hypertrophy too well here. The muscle wall gets bigger, and but an aortic calcification will cause a narrowing of the aortic valve, and a narrowing of the aortic valve will lead to left ventricular hypertrophy. It becomes a very, very muscular heart. Okay. What is this? So what I'll tell you is this calcification in this structure here, but I will ask you to tell me what that structure is.
Yeah, so coming off the left ventricle, I would say it looks like there's actually some in the aortic valve, but up with the ascending aorta.
Yes, so it is in the aortic valve also, and it has gone up to the ascending aorta. So arteries get calcified with age. So people in their 70s start getting, calcification in their arteries that can be sometimes even visible on X-rays. So and when the valves get calcified, then you've got a problem with the working of the heart itself. Absolutely. And here you can sort of see the diaphragm more clearly than you could in the CT that we're seeing. So you can see it on that side. So you can actually tell the difference between the liver, subphrenic spaces, and the diaphragm. And the pleura obviously is attached to the diaphragm, so you can't really see the difference, the interpleural space. All right, let's do this one. And the pathology is here and here.
Okay, so that would be the location of the descending aorta.
Correct?
Makes sense there, just on the right-hand side picture.
Yes.
And yeah, it looks like there's a false lumen.
Yes.
Would that be right?
Yes.
Like an aortic dissection.
Yeah, that is an aortic dissection. There you go. So that's definitely an aortic dissection and maybe even an aneurysm, but definitely a dissection. And do you know the difference between dissection and aneurysm?
There's like a tiny bit of crossover there where
Yeah.
you have a false aneurysm. It's the same as a dissection. Is that right?
Well, a dissection will read. I know I might be wrong. I don't know this exactly, but the difference is a dissection is just a cut in the lumen, and then fluid starts filling in when the lumen gets damaged. Yeah, inside the wall, absolutely. But in an aneurysm, but that will lead to an aneurysm. Aneurysm is a dilation. Any dilation. So you may have an aneurysm without a dissection.
Yep.
So it absolutely that you can have an aneurysm without a dissection, and you can have a dissection without an aneurysm, but an aneurysm will ultimately lead to a dissection will ultimately lead to an aneurysm. So you see that's a cut, and so that's a dissection, and then the blood will start flowing in here and cause an aneurysm.
And the false lumen, that's the section where the blood collects between the wall and that.
I think so. I'm not really sure what it's called. If that might be called the false lumen, but you can have a carotid artery aneurysm, and that doesn't have a dissection because it's a bit of a small artery. So sometimes these aneurysms don't have a dissection, but a dissection is a cut in the vessel wall. So there you go. So nope, that wasn't this one. It was this one. All right, well done. Okay, so that is what is next. We've done that. So that is again calcification in that vessel, but can you tell me what that vessel is?
That would be the left anterior descending.
That is the left anterior descending. Yep, correct. So you know where those structures are, which is great. And it says, yep, calcified left interventricular artery. There you go. And the interventricular artery is the same as the left anterior descending. They've got two names. Oh no, where were we? We were here, this one. What is that structure? And so the pathology is this.
So it'd be your pulmonary arteries.
Correct.
And I think it's probably a saddle piece.
That is a saddle embolus. Correct, a saddle embolus. So absolutely. So big clot comes into the pulmonary veins from the legs or the venous part of the body, and then comes through the ventricles and gets stuck in the pulmonary arteries. That's a saddle embolus. So very good. That's a classic saddle embolus. That's what it looks like. This is a medical emergency and is ultimately diagnosed on CT. So if you, yeah, so you can't diagnose this otherwise. So if you suspect a pulmonary embolus, a CTPA, which is a CT pulmonary, is that an angiogram? Yes, a CT pulmonary angiogram is essential, in which what they do is they put a dye in the venous and the arterial system so this whole area lights up. And so if you put a dye in the venous system, the pulmonary trunk and the pulmonary arteries will light up. And then when they light up, as they go into the pulmonary system, you can see the whole system. And you can see if there's an embolus there. All right. All right. This is actually not a CT. Oh, you actually can see this on CT. That's not a CT. That's an angiography. That's an angiogram. But that's a CT. So you see something.
So if we're looking anteriorly at the heart, it's probably more likely to be the left circumflex, is it?
It could be. I can't. I actually cannot tell which artery this is. No, you can't. Not from this view. You're right. A blockage, yes, or narrowing in a coronary artery. A stenosis is a term. Stenosis in the coronary artery. And I cannot. I don't think through imaging, unless you know where you are, you can actually tell where this is. So you won't be able to tell which artery this is, but you can tell that it is stenosis. All right, and you can see stenosis on CT. Okay, so here they tell you what the arteries are: left anterior descending, left circumflex, and you can see calcifications in them. So that's the circumflex, that's the right coronary artery, and you can see calcifications in them. This is just calcified arteries. So, all right, let's keep going. There's some more interesting things here. Which was this one is the next one? Yes. What can you see here? And what they're pointing at is this. Do you see this darkening of the color? Look at the remaining wall, and this part is darker. And this, you see the same here.
Yeah. So I'd probably say the stenosis had probably a full STEMI actually, because it looks like the ischemic. I would say it's an ischemic patch, and it
Yes.
looks like it's gone through the entire wall.
Correct. So that's myocardial ischemia. Yeah, ischemia, potentially infarction. So look at that. You can see that on the CT.
Right. Oh yeah. So would you say that that's ischemic versus infarction?
You know, I can't say. I actually think an early ischemia wouldn't show up on CT, but a late ischemia would. But that would be an infarction. So I actually think that is infarcted tissue. It may not actually be ischemic tissue. So I am going to have to query infarction. Because it very well could be, you know?
Yeah.
And yeah. There you go. Where was I? Here we are. Similar thing here.
Yeah. Yeah. Same thing, I guess. It would be just
Ischemia slash infarction.
Yeah.
Okay. Oh, wait. Here we were. No, what is this?
A patent Ramanavalli.
Could be a patent, Formanavali, but what, or atrial septal defect, basically.
Right, an inter-atrial connection.
Yeah, that's an atrial septal defect, absolutely. And you can tell the structures: right ventricle, right atrium, left atrium. So this is at a transverse level, and this looks like at a coronal level that you can sort of see. So good. All right, then we've got this one.
Yeah, so probably a ventricle.
Yep, that is a ventricular septal defect. Correct. Good job. What is this? The problem is...
Yeah, it would be an aortic coarctation.
Yeah, coarctation of the aorta, absolutely. And that's how it shows up.
So, is there two?
I can't say, actually. I'll have to scroll forward and back. And I think when I took this image, I wouldn't know. So it's either there or there. But it is a coarctation. And so this is a CT with a stent. And yes, so they've fixed a coarctation there. Oh, I should have pressed that button so you didn't know what it was. But there you go. So that was that. I think we covered a good amount of pathology there. Thank you for watching this video. Please subscribe to my YouTube channel and follow my Facebook page. Please also support my work on Patreon and Kickstarter. It will be greatly appreciated.